Okay, part 6. This should be short because I think I just have this one more slide to go over. But these are factors that affect pharmacokinetics and pharmacodynamics. It's important to understand that if a factor affects one, it's probably going to affect the other one. Remember the slide a few slides back that showed both of them together, that we start out with, when we administer a drug, with absorption and distribution, then with pharmacokinetics, then pharmacodynamics takes place because the drug gets to where it's needed to act. It acts, and whether it is attaching to a receptor and causing the change we want for the desired effect, or whether it's attaching to that receptor, sending a message to the inside of the cell to make the change that we want, or whether it's actually going through that cell membrane. So then, once that drug has done what it's supposed to do, when the pharmacodynamics have been completed, then the pharmacokinetics picks up again to metabolize the drug to a form in which it can be excreted. So you see they work together. So what affects one is going to affect the other. We got genetics at the top of the list. There's a host of variable effects that happens in the body and with the reaction of the body to different drugs. We know that people vary their body type, their weight, their diet. Again, we're going back to that ethnicity and the genetic makeup. These factors can be individually or combined and can cause significant variation in their response to drug therapy. So with genetics, it's a major factor in determining the way people metabolize specific compounds. The genetic differences may result in abnormal or even absence of a drug metabolizing enzymes. We know that we have found that the genetic makeup of people of Japan is known to affect the expression of certain hepatic enzymes that are involved in the metabolism of drugs, so that pharmacokinetically some people of the Japanese heritage respond differently to certain drugs. But there are variations in many of us. There are people who are supersynthesizers of opioids, meaning that the drug is metabolized quickly in their liver, thus the pain-relieving effect does not last as long as a person that is not a supersynthesizer. And there are supersynthesizers of other medications as well. We have to think about age when we are giving medication, developmental differences in the neonate, the toddler, and the young child. They will influence how drugs are handled by the GI tract. Actually, the nephron units and the kidney is not fully developed until a child is 2 years old. And if a drug is excreted through the kidneys, that can be problematic. Actually, drug metabolizing enzymes are deficient in the fetus and in premature infants. And actually, children can metabolize some medications faster than adults. When they reach puberty, that starts to even out to more of an adult reaction. But there are some medications that children metabolize more quickly. Then we have the older adult. They undergo physiological change that affects absorption, that affects metabolism, the liver enzymes, and particularly the kidney. So if they have chronic kidney disease, or if they have comorbidities, if they have comorbidities is more than one chronic illness. So if they have cardiovascular disease coupled with that has caused congestive heart failure, and they do have first, second, third degree chronic kidney disease, then you have to think about these comorbidities and how drugs are going to affect, because these people are on usually multiple medications. So how are these interacting with one another? And we have to bear in mind, are they being excreted? Are they going to get drug overdose, drug buildup. It does, and they pose, someone with a lot of comorbidities does pose a greater challenge for the prescriber. So we as nurses have got to be alert to a drug's effect. What are the signs that the patient may be getting into trouble because of medication? And we'll talk about under safety in the next section that is in this unit, but in my next section of PowerPoints, we'll talk about drug safety and about the drug safety in polypharmacy, because older adults with multiple chronic illnesses can be on 10, 15 drugs or more, and there's a high potential for interaction between those. So we want to catch problems. Prevention should be our watchword, and we want to catch problems before they become huge problems. Sex is another variable, but it's poorly understood. And as we said earlier, most of the published clinical studies use male subjects as their primary study population. But however, women in general have a higher percentage of body fat than men. I mean, that's just a normal, natural thing. That's the way nature made us, so that we can have babies and breastfeed. So we do have a higher fat content, and so that does affect the way we react to drugs. Also, you have to consider the absence and the presence of hormones, particularly estrogen and testosterone. With ethnicity, we've already talked a little bit about it. It is a significant factor in both pharmacokinetic and pharmacodynamics. The genetic makeup of various ethnic populations does govern the levels of hepatic enzymes that are expressed in the groups. Also, there are different lifestyle habits and diet, and there's different uses of herbal or home remedies, and all of these might, because when we do ethnicity, we also need to talk about the cultural piece of this. So they may have a response because of diet that they have, or the home remedies that they use. And we already mentioned the genetic difference of people with Japanese descent. Researchers have also found that African American patients being treated for hypertension do not do well when they are being treated with only one antihypertensive drug, particularly some of the ACE inhibitors, which we'll learn about later. African Americans naturally produce lower levels of renin, which is a key component in the renin-angiotensin-aldosterone system. I don't know whether you remember that from your A&P, but that is an important system that helps regulate vasoconstriction, vasodilation, and fluid level in the body, thus helping manage the blood pressure. So because they have very little renin, then the ACE inhibitors has minimal or no effect for the African American. So you can see how genetic and ethnic differences are going to affect how a drug is metabolized and utilized by the body. And we've already touched on diet, the diet and nutrition, because the drug affects the metabolism of and response diet does affect the metabolism and response to many drugs. We've already discussed obesity. We also mentioned that when we're absorbing medications, that if we've eaten a meal that's high in saturated fat, that's going to delay absorption. Cigarette smoking and alcohol can affect the response to drugs. Foods we eat can affect the response of drugs, and one of the main ones that we'll talk about is leafy green vegetables, particularly like turnip greens. How does that will affect coumadin levels or warfarin? It will counteract. It would be like the leafy green vegetables would be an antagonist against the warfarin or coumadin, which will block the action of the warfarin or coumadin. Also, grapefruit and grapefruit juice interacts and blocks some of the action of the drugs that we give for cholesterol. So food can certainly affect the medications that we give. And as nurses, we've got to know and be aware of these things, because one of our main roles as a nurse will be education. So if we're sending a patient home and they're going to be on Coumadin, or they may be on a cholesterol medication, then we have to know to teach them, you should not take this medication with grapefruit juice, or you need to decrease your consumption of leafy green vegetables, particularly stuff like turnip greens, spinach, those types of things. And then when we talk about pathophysiology, if we have a structural or functional problem in our bodies, then that will affect the metabolism, the pharmacokinetics and the pharmacodynamics of getting that drug taken care of and being able to for it to be utilized in the body. Namely, we're talking about any problem with the liver or the kidneys. Also, decreased blood flow to any organ, let's say, will affect the metabolism and the distribution, of drugs. Going back to the dietary piece, the MAO inhibitors, which are drugs given for psychotic disorders generally, they react badly if you eat aged cheese or aged smoked foods, because they have a component in them that when you mix them with these MAO inhibitors will cause a blood pressure crisis. So getting back to diet and nutrition. So, I mean, we can have very serious reactions if there is a drug-food interaction. And again, back with the pathophysiology, of course, if our kidneys are not excreting well, we can get a toxic buildup of medications. If our livers are not functioning well, then the meds will not be metabolized as they should be. And again, you can get a toxic level of them because they're not being metabolized and broken down as they should. No, your head is probably spinning. This is a lot of material, a lot of complicated material. Just email me if you want to see me face to face, so I can maybe explain some of this. If you're having difficulty explaining it, if you're having difficulty understanding it. On your test, you'll need to understand these principles, but I'm not going to ask you really detailed questions. The main thing is I want you to understand that there are a lot of factors, that it is not just giving the patient a pill. We've got to understand what we're giving, why we're giving it, how it works in the body, what are possible drug-food effects that may occur with this medication. Do they have good liver function? Do they have good kidney function? What's the blood flow like? So it's things that you've got to, in the back of your mind, always remember and understand. What's their age? What's their ethnicity? So you've got to understand the relationship of the pharmacokinetics and pharmacodynamics with the medications and how they're going to affect your patients.